Our next speaker is Dr. Shakeel Modak. He is the chief of the neuroblastoma service at Memorial Sloan Kettering and professor of pediatrics at Weill Cornell Medical College. He trained in pediatric hematology oncology in India, England, and at Sloan. He's been involved in the neuroblastoma research since 1997 with research interests in neuroblastoma biology and immunotherapy. He has served on numerous foundations and government agencies, and his talk today is going to be talking about the approach that Sloan Kettering takes in upfront therapy, and also a brief update on the vaccine trial. Dr. Modak.
Looking at this, okay. All right, thank you so much. First of all, I'd like to thank Pat. She's done this really stellar job for so many years, decades. I think as parents, we really, and as physicians, I think, owe her a big thanks. It's always a pleasure coming. I haven't come here for some time. It's bittersweet for me. I see so many faces, and some people wish we could have done more for. So it's not. It's a bittersweet occasion for me. But I think trying to share some of what we do. We don't have the answers to everything, but because we do things a bit differently, I think it's worth sharing our philosophy and how that has evolved over time. So with that, basically, these are my disclosures. And I want to talk basically about two things today. One is how chemotherapy at MSK evolved and putting it in its context. Many things have been discovered recently, such as the role of chemoimmunotherapy, and MSK, as well as other centers, have contributed to what we feel will be better outcomes, I hope. Also wanted to talk about our overall approach for neuroblastoma, just a couple of slides, and then the vaccine, where things are and where we are going with it. So what is induction chemotherapy? Induction chemotherapy is that chemotherapy that's given up front with the goal of achieving remission. And remission means all the scans are negative. And that's the first step. Basically, in neuroblastoma, we have two goals. First of all, to achieve remission, and then to not let a patient relapse. And if that happens, then the patient's cured. So the first step is very important, and both us and recently COG has noted that achieving remission, that is essentially a Curie score of 0, is critical in the prognosis. So historically, if you really truly look at the remission rates, they have been very suboptimal. So looking at COG, SIOPEN, over time, the response rates have been less than 50% in general, and that's definitely not good enough. What we have done over time, and Brian Kushner, my colleague, has led this, is looked at high-dose induction chemotherapy over time, and much of those regimens which Brian kind of piloted have been adopted by other centers all over the world. And each of these combinations was tested in relapse and refractory patients, and then they were all adopted into upfront chemotherapy. And what have we learned from all that? We learned that, at least in the US, giving high dose of chemotherapy upfront is important. That is, in the old days when we used to give less intense chemotherapy, our outcomes were not as good as they are now. But how many cycles to give, we don't know. We used to do 7 cycles at one point, and then we reduced it to 5, the number to 5, and now we're doing only 4, and I'm going to mention that a little bit. But to balance giving too much chemotherapy and too little chemotherapy is a bit tricky. When we were doing 7 cycles of chemotherapy, high-dose chemotherapy, we saw an uptick in the risk of secondary leukemia, and we were able to mitigate that by going down to 5, and now we're using 4 for kind of a different reason, and I'm going to come to that. One of the heartbreaking toxicities we see in a tangible way is hearing loss related to cisplatin. And cisplatin is a drug that's been included in neuroblastoma therapy for basically historical reasons, not really, never been tested formally in neuroblastoma, but because this is a drug that existed in the 60s and 70s, it got incorporated into neuroblastoma therapy. And our current approach now is to see if we can get by without using cisplatin. But bottom line is that, as I mentioned before, the induction response rates are not good enough, and we've got to do better. And also I'd mentioned that CR, complete remission, QD score of 0, is really important for prognosis. And this has been reported recently by COG as well as us. That is, after, in the 0531 study, patients who had a QD score of 0 did much better than those who had a QD score of more than 0. So we want to achieve complete remission. After working in this field for 30 years, I think what we've come to realize is that one size doesn't fit all for induction chemotherapy. So a group of patients will not respond to chemotherapy at all. And that group of patients, say, start off with a QD score of 30 and end up with a QD score of 25. That's not a good response. We've hit patients hard with chemotherapy and really haven't achieved too much. There's a second group of patients which will respond extremely well to chemotherapy. That disease will melt away, and they will have a very good, robust response. And our thought is, why give more chemotherapy to the first group of patients? Why keep on beating them up when so much chemotherapy really hasn't worked? And another approach should be taken for that group. For the second group, in whom chemotherapy has led to a complete response, then you can also ask a question in two ways. Should we give them more chemotherapy because they've already responded? Or should we stop chemotherapy because chemotherapy has done such a good job? And then a third subgroup of patients are those patients who have not had a good enough response, but have had a good response. Say the QD score has gone from 20 to 5. And in that group of patients, I think doing more chemotherapy is justified. So right now, COG and large international studies use one protocol for every patient, but clearly neuroblastoma is not one disease. It's a very heterogeneous disease. Some patients will have an outcome that is predicated by their genomic makeup or some biological makeup that we don't even know yet, and others will have an exquisite response. So we really don't think that one approach should be applied for all, but we don't have, because it's such a rare disease, it's very difficult to be agile and flexible, but that's what we're trying to do to the best of our ability. So the N9 study, which was again pioneered by Dr. Kushner, used 4 cycles of chemotherapy, and this has been presented at ASCO. And the 4 cycles of chemotherapy is interesting because we do not use cisplatin at all. The first cycle is cyclophosphamide, topotecan, and vincristine. Second cycle is ifosfamide, carboplatin, and etoposide. Third cycle is cyclophosphamide, doxorubicin, and vincristine. Then we do stem cells collection, which we don't use, but we save for a rainy day. Then we do surgery, and then a 4th cycle of cyclophosphamide, topotecan, and vincristine. So the advantage or potential advantages of this approach is that we don't use cisplatin at all. Therefore, we can preserve hearing. And we reduce the dose of doxorubicin to just 1 cycle to minimize the risk of long-term cardiotoxicity. So this is our current approach that we completed accrual on. We treated 15 patients, but there are a bunch of other patients who were treated according to the study. But if you look at the 15 patients, we were able to get enough stem cells. We did not see any unexpected side effects. Obviously, no hearing loss because of no cisplatin. All these patients underwent surgery, complete resection. And the responses were not ideal. So they were similar to what we would see in the old days. That is, we saw complete remission in only 6 out of 15 patients. But what's interesting is that those patients who did not achieve complete response, all of them went into complete response after getting antibody therapy. So in this setting, we were able to give less chemotherapy, but get the same long-term outcomes. So this kind of validates what I said in the previous slide, is that perhaps for some patients you do need chemotherapy, and for other patients you need less chemotherapy or no chemotherapy. So this kind of informs our current study, which actually went through the IRB yesterday, and so we'll be able to accrue as soon as I get back. So we give the 4 cycles of N9 chemotherapy. In those patients who achieve a complete remission, which is the last arrow, we give antibody therapy with naxitamab and GM-CSF. In those patients who have a partial remission, we are going to be doing chemoimmunotherapy because those patients responded to chemotherapy, so we should not abandon chemotherapy altogether. So that's why we're going to do chemoimmunotherapy. And those patients who did not respond or responded very poorly, where the Curie score, for example, as I said, changed very little, those patients will give only antibody therapy and naxitamab. And we can do this with some confidence because in our phase 1 and phase 2 studies, which not all of them have been published, with naxitamab plus GM-CSF, we see very good responses, up to 85 to 90% in those patients who don't respond to chemotherapy, are left with bone and bone marrow disease, and then get naxitamab. So this is the schema of the new study. And after the 2 cycles, we are going to do an evaluation, and we want to get overall response at that point of, we hope to get a response of 75% or therein. And this is not just complete pie in the sky, because St. Jude's, as you know, included antibody upfront, and their response rate was 68%. And when we went back and looked at our own N7 study, which nobody else was able to reproduce, we realized that we had added antibody after cycle 5, and we had reported on 79% response rate. So what all this is put together is telling us that earlier we use antibody in the whole journey, the better it is. And now COG is also asking the same question, whether antibody given after 2 cycles will lead to a better response. Now, response alone does not necessarily mean that outcomes will be better, but based on our previous studies, we have shown that a Curie score of 0 will have better outcomes. So we are hoping that will be proven in this type of study. So overall, for high-risk neuroblastoma, if patients get complete response, we treat them with naxitamab. And if they continue to be in complete response, and I'm going to pivot to vaccine in a bit, we offer them vaccine. They don't have to get vaccine. And those patients who don't respond will get some sort of second-line treatment. But on N10, they're going to get chemoimmunotherapy. And then if they achieve complete remission, they'll get antibody, and then they will be offered vaccine therapy. But this is our overall approach right now. And as you all know, that we have not been doing transplant for the last almost close to 20 years. And when we look at patients who had or did not receive transplant, we have found that the overall survival has not changed, whether patients have received transplant or not. And Jaume Mora in Barcelona has also shown this by showing good outcomes without doing transplant. So we kind of feel validated that our approach, which we've taken some flack for, has been reproduced in other centers. So that's kind of reassuring. And if you look at even the tandem transplant, the real-world experience for dinutuximab, again, shows no statistical, and this is not our study, shows no benefit for patients who received 1 versus 2 transplants. So the study showed there were a minority of patients who were enrolled actually got the treatment, but when you look at all the patients who received 1 versus 2 transplants and got dinutuximab, neither overall survival nor progression-free survival, and this is not even our data, shows a difference. And finally, in the modern era where we do naxitamab instead of mouse 3F8, we see the same good outcomes when we do not do transplant. That is, overall survival of 75% on a relatively long follow-up. So we have not had a reason to re-examine doing transplant. The criticism is that it's a single institution, single-arm study, and that I accept. But at least as a single center experience, our overall approach without doing transplant has held up so far. And now we are seeing the benefits of not doing transplant, and that's been difficult to assess because all the short-term side effects, of course, are much less not doing transplant, but now this is the first evidence from a long-term study where we see that those patients who have not had transplant have been able to preserve their ovarian function much better than those undergoing transplant, and that's a significant observation. So again, I think we feel that we are on the right track, and now after several years, we are seeing even very long-term benefit for these patients. Dr. Laqualia has pioneered the use of, our whole goal is to do the same, get the same or better outcomes with less toxicity. So by using a thoraco-abdominal approach, that is opening the chest and the abdomen together, we have been able to salvage kidneys. Very few of our patients lose their kidneys during surgery, but this is not new. I just wanted to put in here to illustrate the fact that in all aspects of treatment, we are trying to reduce treatment if possible. And finally, in a study that was published, we reduced the dose of radiation to the primary site from 2100 centigrade to 1800 centigrade and found that there were no excess relapses. That means there were really no relapses within the field of radiation. And now we have reduced the dose of radiation to 15 centigrade. We are accumulating patients, and we should be able to analyze the data soon. And we can make a statement or not that 15 centigrade is enough. Right now, we feel that 18 centigrade is enough to prevent local recurrence. And we hope that reducing the radiation will reduce long-term toxicity. A second major concept is that neuroblastoma at relapse is eminently salvageable. And this has been a controversial statement to make, but now, with the advent of chemoimmunotherapy, which is used in many centers, we are seeing patients who relapse. We have been seeing this for a long time, but patients who relapse do go back into remission. Most patients who relapse will go back into remission. And we have always adopted a non-nihilistic approach. Our fundamental approach is relapse is curable, not that relapse is incurable. And the way we used to treat this group of patients in the past is we used to give them chemotherapy, and then we would treat them with murine mouse 3F8. And if you can see from this survival curve in 101 patients that patients who relapsed, went back into chemotherapy, went back into remission, got antibody therapy, about 40% of them never relapsed again. And about 50% of them are long-term survivors. So what it's telling us is that relapse is not incurable. If we don't accept, if we start off with the converse view, then we are not going to help our patients. But if maybe we are wearing rose-tinted glasses, but this is our real-life experience. So that was the pre-vaccine era. And basically, when a patient relapses, we treat them with appropriate treatments, and once they get into remission, we give them naxitamab, and we offer them enrollment on the vaccine study. So this, in a nutshell, is what we do for patients. And in the past, when other centers did not see such robust responses to chemoimmunotherapy, there was much more of a nihilistic approach. And now, because chemoimmunotherapy leads to such good responses, we are hoping that this approach can be adopted everywhere as a default. And chemoimmunotherapy, both with naxitamab and with dinutuximab, and both have a response rate of between 35 to 50%. And I would be perfectly fine with either of these two combinations being used at relapse. But what do we do after that, right? We still don't want only 40% of our patients to be salvaged after the relapse. We want to push that. One of the things that we tested was this vaccine. So most of you know about this vaccine, but some of you don't. Basically, a vaccine is an agent which makes immunity within ourselves. When we give antibody therapy, the anti-neuroblastoma effect lasts when the antibody is circulating, but when the antibodies stop, there's no anti-neuroblastoma immunity. idea of the vaccine is, can we have a low-level antibody response in our body forever or for long periods of time? And so this vaccine was kind of a very old vaccine created by Phil Livingston in the 1980s, and then refined by Dr. Raghupati, and I was involved in the initial preclinical studies for this vaccine as well. And we first noticed that this was safe. We treated 15 patients. The first patient, I believe, was treated in 2003. And 12 of the 15 patients are still alive and have no disease. And only after we noticed this that we decided to expand the study. So we did a phase 1 study to make sure there was no long-term toxicity. Then we did a phase 2 study only in those patients who had relapsed and gone back into remission. So it's important to know the distinctions. So patients relapsed, they got chemotherapy. The chemotherapy got rid of their disease, and then we gave them vaccine as a chemopreventative or a relapse preventative approach. What we found that those patients who make good antibody titers, which is a majority of patients, they tend to do well. And if they did not make a good antibody titer, their outcome was not good. So this is somewhat reassuring. Of course, we want to make it better, but it's reassuring because whenever you have a disease and you give a drug, a disease gets better, we know the drug's working. But when you're giving a drug to patients who have no disease on board, the only way you'll know if the drug is working is by looking at survival. And survival is multifactorial, right? Many things can dictate survival. But when we see a biomarker that is response, and that response correlates to survival, we feel more confident that what we're doing is what we're giving is actually doing something. So in this phase 2 study, we showed that the titer or the response to the vaccine dictated whether a patient did well or not. Another thing we saw was that a polymorphism. A polymorphism is a change in a gene that does not cause disease, but it causes other changes. For example, you and I look different because we have some polymorphisms. These are just slight changes in our genes that don't lead to disease, but lead to some differences. So in this case, if you have a dectin polymorphism in one protein, those patients who have a particular type of polymorphism will do better. And those who have the less ideal polymorphism will not do as well. And that, again, gives us some confidence that this is a biologically active agent, because if we did not see this, then we would just say, oh, some patients are randomly responding and others are not. But we also want to help patients who don't have the right dectin polymorphism, and that's the reason why we continue to improve the vaccine. So we first reported on 108 patients in second remission. And those patients were all treated with vaccine, and those patients who had relapsed only once before, that is in true second remission, had a long-term survival, event-free survival of more than 50%, suggesting that this data looks better than our previous era where we did not use vaccine. But if you had more than one relapse, 2 or 3 or 4, some had 6 relapses, you did not do as well, but that's basically common sense. We did not see any side effects, and as I mentioned, the response, anti-neuroblastoma response, and the dectin polymorphisms were important. So we learned this from the first group. Another thing we have discovered is that an agent called beta-glucan is important. And this is also important, but also expensive. So we looked at whether we should give beta-glucan early or whether we should beta-glucan late. And that was the second group of patients, again, about 120 patients. And we concluded that giving beta-glucan earlier on was better. And so now we start the beta-glucan along with the vaccine. And there's a lot of science behind this, which I'm not going to go into today. So that was the second cohort of patients. Now, many of you are rightfully interested in what happened to the first remission patients, because about 5 years ago, 3 or 4 years ago, we started including first remission patients as well, because we want to optimize the vaccine and say, how do we go ahead with vaccine we need to have a multi-center study. We need probably to do it here and in Europe, and we need the backing of pharma. So far, none of this is happening because we're still making the vaccine at MSK. We still haven't been able to do a multi-center study because we don't have pharma backing. But we want to be in a position to have a best vaccine. If pharma comes in, then we have the best vaccine to give them. So that's our effort right now. That is the real goal of continuing the vaccine study. And for example, if you don't have the right dectin polymorphism, can we do better in that group of patients? Or how can we make the response better to vaccine so that the outcome will be better? These are the questions that we're currently asking. In order to answer the question whether this is going to be useful in first remission, we will have to do either a randomized study or we will have to treat hundreds of patients, because already in first remission, if you start the clock after finishing antibody, and if you're clean then, all the scans are negative at the end of antibody, it's at least a 65% cure rate. That is 65% long-term survival. So if you want to improve that number to, say, 80, 90%, we'll have to either do a randomized study, that is, treat half the patients with vaccine, other half without vaccine, or we have to treat hundreds and hundreds of patients, which is very difficult in a single institution. But for those patients who relapsed, then got back into remission, a textbook will tell you that most of these patients, or 90%, will relapse, which we don't agree with. But in that group of patients, we are reasonably confident that we are doing something. So that's where the vaccine trial is currently. And what are we doing now? We are trying to improve this vaccine further by adding a drug called GM-CSF. GM-CSF is the only adjuvant, that is only combination used with vaccine which has FDA approval for a cancer vaccine. So that was a logical choice. And so now the current study is randomizing patients into getting the standard vaccine versus the vaccine plus GM-CSF. And if you can show that the outcome is better, titers are better, then the GM-CSF will become standard. So we want to be in a position where we can then, when we are ready to do, or people are ready to do the phase 3 trial, we have all these things sorted out. And finally, again, as I was mentioning, how do we do better with the vaccine? We are using what are called adjuvants. Adjuvants are molecules that make the vaccine work better. But the adjuvants that we're using now really come from the 1960s and 70s. And so we want to bring the newer adjuvants. For example, for pneumococcal vaccine, meningococcal vaccine, it took a long time for these vaccines to be approved, because people had to learn how to make these bugs more immunogenic or make immunity against them. And they did that by using newer agents, so-called CpG motifs. And so going forward, we will have to look at that. Can we make the immunity better using 21st century adjuvants? Can we overcome the negativity of dectin polymorphisms in some patients? And of course, I mentioned we can't do this alone. We spend more than $1 million a year out of philanthropic funds to make the vaccine, to buy the glucan, and to run the trial. And so it's really not set up. We are not set up to do a multi-center study. Then we have to think about how can a multi-center study be done in the first place, because if DFMO has been approved for patients who've received dinutuximab, and so these are some really real-life questions which people are struggling with. Again, our goal is to optimize the vaccine at this point. So I think that's pretty much what I have to say. And of course, I have to, again, thank CNCF. And there's too many families, patients, and donors and foundations to thank. We have a very dedicated team. We have about 40 people who work only on neuroblastoma, including nurse practitioners, attendings, and a big data management team. Nurses' only job is to administer naxitamab. And so we recently had a retreat where there was a lot of disinhibition going on, but it was fun to hang out with everyone. So thank you.
Thank you, Dr. Modak. Does anyone have questions? Yeah, a couple over there.
First off, thank you. So for MICN amplification, how does that impact your approach and/or your outcomes?
In the modern era of modern induction chemotherapy, high-dose chemotherapy, MICN is not a poor prognostic marker, both for us and for COG. So MICN amplification, I dare say it might actually not be a bad, maybe even a good marker, because patients with MICN amplified disease, they would not respond to 30-year-old chemo or 20-year-old chemo, but they respond really well to high-dose chemotherapy. So whenever we talk about prognosis, it's in the setting of the treatment you give. If you give less chemotherapy, MICN is a bad player. If you give more chemotherapy, MICN is a good player. Patients with MICN amplified disease who don't do well are those who don't respond at all, or in whom soft tissue disease cannot be resected. And that group of patients, extremely frustrating group of patients, we have not been able to help. So something other than MICN is driving the behavior of the tumor, and that we've got to figure out. But it's not only the MICN doing it. That's a small number of patients in the modern chemotherapy era. So the answer to your question is, I don't think we need to change anything for those patients who had a good response.
Okay. And does that impact if there were a relapse? Is it more
relapse?
Important to,
MICN amplified relapse in the
outcome
first year of life, first year from diagnosis, is incurable, cannot be cured. And that's unfortunate. This is the group of patients who we struggle the most with, those patients in whom surgery was not possible or did not go into CR, or those who responded, relapse within months of finishing treatment. But once you're out of that early phase, then I think we see very, very few late MICN amplified relapses.
Got it. Okay. Thank you.
Sure.
Okay, one question here, and then we'll go to you.
Yeah, I have two questions. The first one is for patients that get immunotherapy up front, like during induction, does that change the effectiveness of targeting the GD2 later during treatment?
We'll never know the answer to that. There are two things that could happen. One is that you could reject the antibody, that is, make a human anti-chimeric response or a human anti-human antibody response. I don't think that will happen, because chemotherapy always obtunds that response. So I don't think that will happen personally. Of course, it remains to be seen.
Okay.
The other question is, why will it make it work less better? That will happen because we might lose the GD2 antigen. I know Dr. Reynolds had talked here, but we don't really have very good ways of looking at GD2 in real life. And to answer that question is difficult.
Yeah.
Personally, I don't think it will be a negative. That's my personal opinion.
Okay. And the second question is, what can we as parents do to help get pharma support for the vaccine? Like, what can we do to advocate and help get the ball rolling on that?
I think ultimately it's the market that dictates what drug is, brought forward or not.
So it's like joining like the FDA advisory board?
As some of you may know, that there was a COG study planned, which we were fully participating in, of doing a multi-center study for the vaccine. But to find enough patients in second remission to test it in is going to be difficult. But I think I'm still hopeful, because more and more patients are now achieving second remission. So I think it's still worth bringing to pharma to see if they're interested. It's a lot of outlay in terms of money. But I think the more we advocate for ourselves, we keep on advocating.
Okay.
So much as, other drugs too, and other agents. There's
Yeah. I mean,
access
that
to
holds true
everything.
for everything, right?
Yeah.
And with an agent like vaccine, when you don't have a response to measure,
Yeah.
one of the other things that we are doing is to look for minimal residual disease. So you heard a little bit about liquid biopsies. Liquid biopsies, even though the hope is a lot, we don't have a test that will tell you I do a liquid biopsy today, and that will predict whether you're going to relapse or not. We know that liquid biopsy numbers improve with treatment. So you give treatment, the numbers fall. But the same thing can be said of an MIBG scan. You give treatment, the MIBG scan gets better. Give treatment, the liquid biopsy gets better. But the real need is to find the right liquid biopsy to predict a relapse. And that we are not there yet. Now, if we had such a test, then we could do this test for a vaccine patient and said, look, this patient's liquid biopsy responded to vaccine, and that patient is not going to relapse. This patient, liquid biopsy, did not respond, and take the patient off vaccine. So that test could be, if that test comes into play, that might be one way to make a vaccine trial easier to do. You can say, I'm going to stratify based on liquid biopsy. That's a thing which we're actively working on.
Okay, thank you.
Okay, question?
When you first talked about taking out cisplatin and adding more vincristine, is there...
Ifosfamide carboplatin.
Yeah, the ice, and then
Yeah.
the 3 cycles with vincristine. Is there more concern for more neuropathy versus getting rid
I mean, in
of
the
vision
grand scheme of
loss?
things, that's the least toxic drug.
Okay.
And
then-
anyway, and COG has 5 cycles, right? So they are getting 3 cycles of vincristine anyway.
Okay.
The main thing is, can we get away without hearing loss? And I mean, as someone who sees patients a lot, it can be depressing to see hearing aids and so on.
And then for Danielza, what is MSK's pain regimen?
That's a good question. We are increasingly using, and we haven't published the paper, but I hope to soon, using ketamine.
Okay.
2 things to mention about Danielza pain regimen. One is what Dr. Mora has published or will be publishing about giving Danielza in a step-up way. So you start at a very low rate, and then you go up and you go up and go. And that has been shown to reduce the, not reduce the pain, reduce the allergic type of reaction. Regarding pain, we have had success with ketamine. And using ketamine, we've been able to reduce the amount of narcotics that we use. It's still not completely pain-free. Ketamine is not approved for outpatient use, so we are doing it this is all being done by our palliative care team who prescribes and monitors it. So it requires some input. But once we put it out there, I think this will definitely help with the pain.
Okay. So you guys don't sedate with ketamine?
No. Ketamine is not a sedative. It actually slightly increases the blood pressure. So the sedatives that have been used by other folks, including Ativan drips and I think even with dexmedetomidine, I think those are hazardous because you can't really, they can impact the blood pressure negatively, and then we might cause more problems than benefit. But because ketamine doesn't do that, that's a good drug, at least from our side.
Okay. And then I just have one 2-part question is related to the GM-CSF. If a patient is allergic to GM?
No, there is still a vaccine. I didn't mention this, but there's a sub-arm for that group of patients.
So they could get the vaccine
Yeah.
with GC
Yeah.
instead? Okay. Thank you.
All right.
Okay, one more question here.
COG uses ALK positive or ALK amplification as a prognostic factor. How does your facility view ALK when patients are ALK positive for a mutation or an amplification?
I mean, you're going to get a very controversial answer from me. But the data which was published in the phase 1 trial, phase 2 trial for lorlatinib, that needs to be read carefully. In that paper, response rate of lorlatinib to patients less than 15 years of age was 9%. More than 15 years was 61%. It's telling us something, why this is such a strange phenomenon. And we recently published our own paper in adults, where again, the response rate is very good. But we don't see a good response rates for lorlatinib in children, which is opposite of what we should see, because we can dose up, escalate the dose a lot in patients with, in children. Whereas in adults, they have so much toxicity that I have to shut down the dose at 100 milligrams. So we don't know. We have to figure that out. But in answer to your question about the amplification, amplification is invariably seen with MICN amplification. It's almost never seen without MICN amplification. And what's driving that tumor is the MICN amplification. Amplification is a bystander. So I don't favor treating that amplification with lorlatinib. Other people have and do, but because there's so few patients without MICN amplification, we'll never know whether it's useful. So.
Thank you. I appreciate that.
All right, just 2 questions and that's it. Okay, sorry.
I was wondering if there's any data related to patients that may have done the vaccine multiple times, or maybe they had relapsed while on the vaccine, or maybe relapsed, after the vaccine, and any promise to do it multiple times?
Yeah, we just published that paper on 32 patients who had received vaccine and then relapsed again, and then got vaccine again. Really, the idea is that it's a small group of patients, so I don't know what's what, right? But the whole idea is that whenever you do vaccine therapy, the duration in between shots matters. So sometimes when you do vaccines all together, then you may overwhelm, kind of drown the immune system. So preliminary data from this group suggests that for that group of patients, we should actually space out the vaccine more. So we are actually spacing out the vaccine. But there are several patients in that paper who were successfully retreated or did not relapse after the second round. But there's a lot to learn. So we continue to endeavor to do that.
Okay. Last question.
First off, I just want to say, we did the MSK approach in Minneapolis. So I'm not attacking, but why does COG not do? Because we did all the research, and to us, it just made more sense. The data made sense.
I mean, I hesitate to say making sense means right. In the absence of hard data, right? Although, obviously I bring my own bias because we don't do transplant, so I can easily say, what the hell, why do transplant? But I think the data should really dictate it. For us, the data we look at the data in a positive way.
Yeah.
The real answer is that neuroblastoma is a rare disease. So if the COG powers their studies to look at event-free survival, if they powered the studies to look at overall survival, a study which already took 13 years to complete will take 20 years to complete. So there are some restrictions about how to design a study. My personal view is that randomized study in such a rare disease will have some limited value, not the best disease to look at a randomized study, but that's a controversial statement I'm making. Okay. But there is, I think Dr. Pinto talked about looking at a randomized trial of transplant versus no transplant. But I fear that will take a very long time. And during that time, other more effective treatments might emerge, and we may lose those treatments if we do a very big randomized trial. So I think that that's a controversial subject.
Yes, and we went to Minneapolis and worked with Dr. Rawaz a lot. And he kind of seemed to edge towards your approach, but I've heard a lot of stories of other patients not being able to get the treatment they want with your approach and having to travel.
Again, I don't want to sell our approach as being the best, right? No. Because I don't know it is, but there are other folks, other kids who have also not received transplants in other centers. But there needs to be some data to support it, and I really don't want to say that this is the way to go, but there has to be some sort of study, I think, to...
Okay. I haven't been able to get a good answer from anyone, like an oncologist with COG, not just a good explanation on why their data, so I just figured I'd ask.
I mean, I'm exactly the wrong person to ask this question.
Well, I figured you'd be a little bit less biased.
Yeah, but I think we don't have 100% cure rate, right? So no, I think there are some patients who might benefit, and the trick is finding that patient. Maybe big data or AI or machine learning might be able to help, which we are also have a big project with that. But this is a rare disease,
Yeah.
and so it's difficult.
Okay. And one more quick question. When she was talking
Quickly.
about sedating with ketamine, I think you might have misunderstood because we did, like what Barcelona does with their pain regimen is what our pain team in Minneapolis did. I mean, we switch hospitals now, but I think it's like 70 milligrams per kilo per hour. And I mean, he's like a sedated state. Is that something you guys do, or is that?
No, when you say sedation, it means giving agents that can reduce the respiratory rate
Yeah,
and can
that's-
reduce the blood pressure. Those are dangerous things in my view.
Yep.
But other agents are, ketamine, for example, is good.
Okay, that's just that. I felt like there's a miscommunication there. I just wanted to be.
Yeah, no, that's what, sorry, good. Thanks
Yeah,
for,
perfect.
just to clarify that, yeah.
Yeah, because I know not everyone here does.
Yeah.
Okay. Okay. Thank
All
you,
right,
Dr. Modak.
thanks, everyone.
Thank you.